Welcome, everyone, to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Noha Abalada from Roots Community Health, reporting for the week of March 3rd, 2025. As health professionals rooted in Oakland, serving some of the most marginalized communities in California, we're here to cut through the noise and bring you the latest information on health issues relevant to us all. In today's briefing, following a status update on respiratory viruses, we'll discuss the ongoing measles outbreak as well as more recent events related to public health communications and decision-making. First, taking a look at respiratory viruses, and this is the percent positive of each of these different viruses each week. Influenza is in the bright blue towards the top, and we can see that it is finally coming down, but it still is comprising the vast majority of specimens. Remember that this is only representing tests that were done in a clinical setting, so it does not include home tests. And of course, it doesn't include people who don't get tested during their illness. Now, taking a look at emergency department visits for the big three viral respiratory illnesses, COVID, influenza, and RSV. And they're now depicting this differently on the CDC website. Instead of having all three lines on the same graph, this week we can see that they are separated out into three different graphs. And all three of these graphs are showing us through February 22nd, 2025, so a little over a week old now. And we can see that it looks like for all three that the winter peak of emergency department visits for these illnesses appears to be behind us. And so, of course, no guarantees about that, but we see the flu graph, which is in the middle in blue, is coming down, and then the COVID on the left, as well as the RSV on the right, seem to be leveling off. Neither COVID nor RSV got as high as influenza emergency department visits this winter season, but we know that this has been a particularly severe winter flu season with a very heavy burden in terms of emergency department visits, hospitalizations, and death. And this does happen some years, so some seasons are just worse than others. But as I went into some detail on in the last briefing 2 weeks ago, this is a particularly severe flu season. It's also not uncommon for flu to kind of have a double peak, but we're now in March, so hopefully the worst is truly behind us, but we'll keep an eye on it. And still, even if we are coming down from the peak, it still means we will have a ways to go as things head back down. Similar story here with hospitalization rates. Flu hospitalizations are coming down nicely, and COVID and RSV hospitalizations are continuing to level off or slowly trend down. And again, no question, this has been a particularly bad flu season. Remember, flu season basically starts in early October or so. So from that time through February 22nd, we have seen about 37 million flu illnesses, 480,000 flu hospitalizations, and 21,000 flu deaths, including 98 pediatric deaths. And just like with COVID, people who are at high risk of a bad outcome from flu should be tested and treated as quickly as possible. And of course, we know that the flu vaccine reduces the risk of hospitalization and death. And even though the optimal timing for the flu vaccine is before we're experiencing all of these huge numbers of cases, but having said that, if you haven't gotten the flu this season and you haven't gotten the flu shot this season, you would still get the benefit of protection for the remainder of the season, even getting it at this later date. So that is something to consider. And this slide is showing deaths from the three respiratory illnesses. And again, influenza is in the blue. So when we look out towards the right, we can see that we are looking through February 15th. So just lagging behind by a few weeks. But the 4 weeks leading up to that, we can see that the blue part of the bar, influenza, is bigger than the orange part of the bar, COVID, meaning more influenza deaths than COVID deaths for those 4 weeks. And this is significant because this is actually the first time since the onset of the COVID pandemic that we have had even a single week where flu deaths exceeded COVID deaths. So since about spring of 2020, so that's about 256 weeks. And these are the only 4 weeks, the first 4 weeks where flu deaths actually exceeded COVID deaths. So this is just to try to put things in perspective about the moment that we're in. We want to be careful how we interpret this. I think it's fair to say that this signifies a couple of different things. So first off, like I've been saying, it signifies that we had a terrible flu season. And we know that flu is a significant cause of sickness and death pretty much every single year. And as we know, some years are just worse than others. It also signifies that we are having a less bad COVID winter this year. So that's, of course, a good thing. And we'll take what we can get. But we really don't know what that's going to end up meaning. For example, we don't know whether we'll have a spring wave this year or whether we'll have another bad summer wave like we did last summer, because we know that vaccine uptake was generally low. And if we also then had perhaps fewer infections, then we may have a less protected population as we head into the warmer months. So this is just something that will remain to be seen. But I think it's probably worth noting that this past summer, we peaked at 1,353 deaths in the last week of August, which is shown there as the burgundy bar. Whereas the worst that it got this winter was 1,009 deaths the week ending January 11th, and that is shown on the orange bar. So this is actually the first time since the start of the pandemic that our winter peak was lower than the peak the summer before that. So, and of course, these things could be related to each other. So there were so many COVID infections in the summer of 2024 that it's certainly possible that this is what helped keep cases a little bit lower for the winter, because more people were protected from the summer infections that they got. But of course, we know that the protection decreases over time. So like I say, we don't really know what this is going to mean going forward. It could mean a spring wave, it could mean a bigger summer wave, or maybe things will continue to trend down overall, which of course we would love to see, but we will just have to continue to keep an eye on it. But still, no matter how you really look at this is quite a lot of death still from this virus, especially since, unlike flu, which once the flu finally does come down, it will pretty predictably come down to zero deaths, whereas COVID will continue to cause hundreds of deaths each and every week, like it has been. And there have already been more than 6,000 COVID deaths so far in 2025. So we really do need to do better than this. And what that means is, especially for people who are at risk of a severe outcome like hospitalization and death, those are the folks that need to be ready to get tested and treated as soon as they have symptoms, and to retest and to make sure we know what's going on if it's something that is treatable. These are also the folks that may need vaccination twice a year. So those with immune compromised, those who are 65 and up, are recommended to get the COVID vaccine about every 6 months. And we know this is really not ideal at all. We don't have other vaccinations where this is the suggestion, but currently, given how much circulation of SARS-CoV-2 there is in our environment, how quickly our protection wanes, this is currently the best strategy we've got for folks who are at risk of a bad outcome. Ultimately, I do think we need better vaccines, ideally ones that will elicit a more robust immune response that will last longer, maybe be more variant proof. But one thing you might have noticed if you've been watching the briefing for a while is that I have not really had to share the variant proportions very often these days. At one point, we were talking about them every week or two because things were evolving that rapidly. But it has been a while since we've encountered any new variants of concern. Of course, SARS-CoV-2 is always picking up new mutations, it's always evolving, but it's been a while since anything has concerned us for getting around our prior immunity. So of course, we hope that it will stay that way. It does remain to be seen whether there will be a recommendation to change the formulation of the COVID vaccine this year or not. Haven't heard anything. I'll talk a little bit more about something related to this in a moment. But of course, we are in a much better position if we are not constantly chasing after variants. But having said that, even without any new variants, the issue is that the immunity that we seem to develop, whether from vaccine or from infection, simply does not last very long. And we still have questions, so many unknowns about the impact of repeat infections, as well as the risk of long COVID and post-COVID issues from each infection, but also as a result of multiple infections. Is there a cumulative impact, which has certainly been suggested in some of the data? So having this ability to just keep getting reinfected time after time and multiple times, even in 1 year, we don't want to just continue unmitigated. So taking a look at SARS-CoV-2 in the wastewater, it is considered low to moderate and looks to be decreasing in all regions. So that is also good news. We hope to see that continue down for a while before making its way back up. Now for an update on the measles outbreak. In Texas, the last official count coming out of the Texas Department of State Health Services is that there are 146 measles cases. We've seen bigger numbers than that in the media, but I will go by the Texas State Department of Health, and 146 measles cases have been identified thus far. 20 of those patients have been hospitalized. Sadly, one school-age child has died. This is the first death in this outbreak, and this is actually the first measles death in the United States since 2015. This child was unvaccinated, and it is really difficult to imagine what the parents must be going through. My hope is that this tragedy will help others come to the decision to protect their children from dying a vaccine-preventable death. And as tragic as this death is, it's not really an anomaly in the sense that for those who are unvaccinated, if they contract measles, there's about a 1 in every 350 to 500 chance that they will die, even with the best medical care. So we don't really have specific treatments. We're having to really do supportive treatment. So even with the best medical care, there's still going to be 2 to 3 people out of every 1,000 or so that are going to die. So once we're in the 150, 200 range, having a death, it's very tragic, but it's also not a complete shock. Texas officials are stating that additional cases are likely to occur in the area and in the surrounding communities. I think we know that. We have there a pocket of very low vaccination rates. But it doesn't appear that there have been any of the emergency measures that you might have expected or that we may have seen in years past for an outbreak of this size or of this nature. So for example, by declaring a local state of emergency, they'd be able to do more to stop the spread. For example, quarantining people who've been exposed, keeping unvaccinated children from going to school for the incubation period. But it seems that without this, and really with relative silence from leaders in Texas, the choice seems to be to just sort of allow things to proceed and allow people to make the choice. I'm sure that there's a lot of very dedicated people there on the ground encouraging vaccination, as well as identifying folks who need post-exposure prophylaxis. Hopefully we'll be able to hear about some of their efforts and their trials and tribulations as time goes on. But unfortunately, in this moment, we're really not hearing or seeing much that would give us reassurance about the way things are going. In addition to the 146 cases in Texas, there's also 9 cases reporting in neighboring New Mexico as of February 28th. So we'll just kind of keep an eye on that outbreak. There have been other cases in other parts of the country as well, but really this is the outbreak that we are watching as it evolves. Among the cases in Texas, the majority are in children. In fact, over 80% of the confirmed cases are in children 17 and under. So this is really concerning. And of course, it is not just death that we are worried about. It is pneumonia, it is brain swelling, it is neurological issues, it is developmental issues as time goes on, if there are neurological complications, and the things that we just do not want to unnecessarily expose our children to. And by contrast, we don't see any of these issues as a result of the vaccine, but we do see the protection from the vaccine. So there's just no upside whatsoever to infection. That is reckless and just it makes no sense when we look at the science. And the last briefing, I alluded to a later complication that can happen after surviving the acute phase of measles. This is something I was hoping to avoid talking about. It's very rare, but a very feared complication that I really am only bringing up now because we seem to be heading into a time where we are going to have to familiarize ourselves with measles and all of its sequelae, whether they're immediate or potentially longer term, just like we had to in the pre-vaccine era, because we are unfortunately trying our luck without the vaccine in many pockets across the country. So this particular complication is called subacute sclerosing panencephalitis, or SSPE. This is a fatal disease of the central nervous system. It can happen 7 to 10 years after a person has had measles and survived. So even though they seem to have recovered, this progressive fatal brain disorder can come about in about 1 in every 10,000 people or so. It can come about 7 to 10 years later. So again, rare, not something we want to panic about, but something we need to know about, because this has basically been unheard of in the United States for decades now. But since we are opening the door for some of these horrific things to return, I think is really important that we just be aware of it. So for those individuals that are getting measles now and who survive, it's something that we're going to have to be knowledgeable about. It's more common in children and adolescents. So unfortunately, that's the majority of who we're talking about in this particular outbreak. More common in boys. The first stage involves personality changes. And again, this could be 7 to 10 years after surviving the acute measles infection. Personality changes, headaches, things like that can last up to 6 months. And then after that, things get progressively worse with uncontrolled movements, and that can be kind of like jerky movements, and then they can turn into twisting movements, and then issues with the areas of the brain that regulate breathing and blood pressure, with which then leads to coma and death. It is considered 100% fatal within 1 to 3 years, a very difficult 1 to 3 years from the onset of those symptoms. So back to the Texas measles outbreak, of course, the vast majority are not vaccinated. There are also a significant number where the vaccination status is not known. They're still working to figure that out. At least 5 of the people who got measles had been vaccinated with at least 1 dose. And I think we're really going to want to learn more about these individuals. So was it 1 dose? Was it 2? How long ago were they vaccinated? Any other information that might help us understand the risks for today's scenario. General guidance on this is that if you were vaccinated in 1968 or later, you should have a lifetime of protection against measles. If you were born before 1957, there's kind of this assumption that you were infected with measles, but that's only an assumption. If you were born after 1957 and got vaccinated before 1968, then you need to receive another measles vaccine dose. And if you're just not sure, it's worth discussing with your medical provider. They might choose to check your antibodies. They might just suggest you get another dose of the vaccine. 2 doses of the vaccine is said to be 97% effective, which is excellent, especially since this is thought to be 97% effective for your lifetime. Of course, this leaves 3% that don't get protected. But this is very high efficacy. This is, of course, very different from some of the other vaccines where the effectiveness drops off over time. So something like the pertussis vaccine starts to lose its effectiveness over time, which is why it's not uncommon to hear about pertussis outbreaks, for example, in high schools. It's also why we need boosters, because the effectiveness of that one decreases over time. But with MMR, there's no recommendation about any types of boosters at this time, although I will say that all of this is being put to the test now, particularly in areas where vaccination rates are dropping below the threshold that we need to protect the community. So now we're gonna really find out. So we will continue to keep an eye out for any updated recommendations, more information on those individuals, anything that we can learn in that regard. Now, for those who are in these areas where there are where the outbreaks are currently happening, or if you were planning to travel for some reason to this area, or actually any area in the world where there are outbreaks going on of measles. If you are traveling with a baby 6 months to 1 year, it may be recommended that they will get an early dose. So please don't forget that traveling with baby between 6 months to 11 months to an area with measles, then you may need to get your baby that additional dose, that initial dose. And then they're still going to have to get the 2-dose series after that. Now, if you are in one of these areas and you are exposed or potentially exposed, and you're not able to readily determine that you have immunity against measles, then you should be offered post-exposure prophylaxis. This is something actively being done in the outbreak areas, but just for purposes of awareness, it's good to know that there are 2 types of post-exposure prophylaxis. By no means are these a silver bullet, so they may provide some protection. They may reduce the severity of the clinical course if they're administered within the recommended time frame, and it's a short time frame, so MMR vaccine within 72 hours, or immunoglobulin if you can get it within 6 days. So I'm not sure if you're against the MMR vaccine and then you get exposed, you are going to be strongly recommended to get the MMR vaccine. And that recommendation definitely hits different when you are faced with all of the things I just mentioned earlier, because you're exposed and you're not protected. So just something to think about. It's a lot more effective if you get it ahead of time than trying to get it post-exposure, and you're going to end up getting it anyway. So something to think about. So just to recap, measles, most contagious infection known to humans. One person can spread it to many, many susceptible people in a very short period of time. Even after a person leaves the room, they can leave behind infectious particles for hours that can infect susceptible people. If you don't have prior protection and you come near or even behind someone who's contagious, you have about a 90% chance of getting infected with measles. And in addition to the pneumonia and the encephalitis and the hospitalization, all the things I mentioned that can happen in the acute phase, as well as the SSPE that could happen a decade later. The other thing that measles brings with it is that it is known to wipe out some of your immune system. So all the antibodies that you've gotten before from infections or from vaccinations effectively get wiped out. And so you end up being more susceptible to other infections. And I talked about this in a little more detail in our last briefing. I have put the link to that in the post if you are interested. And if you suspect measles, contact your physician or public health department as soon as possible. Please don't visit every single emergency department in the area. This is how we are just spreading it around. So please be mindful of that and use caution there. Now, I just wanted to provide an update as best as we can tell regarding health, communication, and decision-making at the national level. Specifically, I wanted to share a few things. First, 2 important meetings have been postponed. The first meeting is the CDC's Advisory Committee, which is called the Advisory Committee on Immunization Practices, or ACIP. We've covered many of these meetings here. They share so much valuable information and important recommendations come out of this committee. The meeting was originally scheduled for February 26th to February 28th, so a 3-day meeting. These are very long meetings with a lot of information. I've linked the agenda in the post in case you might be interested in what was going to be discussed, or hopefully what will be discussed whenever they reschedule it. But these meetings are so helpful because they walk through very important data sets, as well as the framework for how they're making decisions and how they're making recommendations. So you can clearly see as they walk through the evidence to recommendations, along with all of the different clinical considerations they may have. Everyone does not always agree as far as members on the committee. They take public comment. Members of the public often don't agree. We don't always agree, but you get to see how the decisions are made. You get to see how members of the committee vote in terms of the recommendations that are then made to the CDC. So some of the vaccinations that were going to be discussed in that meeting included meningococcal vaccine, influenza vaccine, RSV vaccine. That's a relatively new one. I was looking forward to seeing that information. HPV vaccine, Mpox vaccine, including data on this vaccine in young people, Also, there was going to be an overview on the COVID vaccine. And importantly, there was going to be a discussion and voting regarding the influenza vaccine, including how influenza vaccines are distributed through one of our key vaccine distribution programs in the United States, which is the Vaccine for Children program. And there was going to be a discussion about the 25-26 COVID-19 vaccines. So a number of very important and timely topics, yet the meeting was postponed and we don't have a date. The note on the CDC's website says that the ACIP meeting will be postponed to accommodate public comment in advance of the meeting. So we don't really know how long that will take or when the meeting will be rescheduled for. And there's nothing that we can tell that would preclude the CDC from receiving public comments by now, or receiving them right now, or just receiving public comments as they always do. So it's a little unclear what the issue actually is. And then the second critical meeting is the VRBPAC meeting, which is the advisory committee to the FDA, so the Vaccines and Related Biological Products Advisory Committee. And that meeting was scheduled for March 13th. And at that meeting, they were going to be discussing and recommending the composition of the influenza vaccine for the 25-26 flu season. So now is the time to determine strain composition for next year so that it can get into production and so that it can be ready by the start of the flu season. And being that we're in the middle of the worst flu season that we have had in quite some time, this is definitely another concerning move. So the FDA did post a notice stating that FDA continues to work with federal and international partners and with the US licensed flu vaccine manufacturers to prepare for the upcoming season. And they state that they don't anticipate any impact on vaccine supply or timing of availability due to the postponement of the meeting. And so ironically, I think we can be a little reassured because the World Health Organization announced its recommendation for influenza vaccine composition for the 25-26 Northern Hemisphere flu season. I linked that in the post in case you're interested. They provided those recommendations on February 28th. They're recommending a trivalent vaccine, and just depending on the type of vaccine, they kind of list their little recipe there for the vaccine. And typically the US does follow the World Health Organization recommendations on the flu vaccine composition. And interestingly enough, even though the United States has indicated its intended withdrawal from the World Health Organization, the US did have representatives at that World Health Organization flu vaccine meeting. So even though the CDC didn't announce that it was going to be participating, and even though the current administration has indicated its intent to withdraw from the World Health Organization, we, I think, can be reassured knowing that the process did move forward. The United States was at the table, and we have a flu vaccine composition recommendation that we can follow, despite the cancellation or postponement of our own advisory committee meetings. So this strikes me as a bit ironic. And just in case we need a little more irony, while the HHS director said that the ACIP meeting was postponed in order to allow time for public comment, simultaneously, HHS Secretary, RFK Jr., released a policy that actually prohibits public comment during the HHS rulemaking process. So for over 50 years, the public has been engaged in the rulemaking process of Health and Human Services. And on the one hand, we're hearing platitudes about radical transparency, yet on the other hand, we've got public meetings being canceled and postponed, and we've got a prohibition on public comments in the Health and Human Services rulemaking process. So what to do with all this? I think we're just going to have to wait and see how things play out. But in short, I feel reassured that the World Health Organization is living up to its charge as it relates to global health efforts to mitigate the impacts of influenza. And I simultaneously do think there is a reason for concern about what level of accountability and transparency we can expect to see in the coming months to years. So in the meantime, we should just keep doing what we know to do to protect ourselves and our loved ones and our communities. We want to make sure that we are getting our vaccinations that we are due for, that we are protecting ourselves when we are mixing or indoor environments. Wearing an N95 or KN95 mask will provide you the best protection. Gather outside. It's always safer than inside. And if you are going to be inside, let's pay attention to the air quality. We want to think about those best practices for healthy buildings. And then, of course, we want to strategically and timely test and get treated if you're someone who needs to be treated. Stay away from others so you don't give them what you've got. And if you don't have a primary care provider, please get one, develop a relationship with them, make sure you are getting the appropriate screenings and vaccinations based on your age and on your risk factors. If you don't feel well, especially if you're someone who should be treated, please get tested to see if you have flu or COVID so that we can get you started on those antivirals right away. The sooner the better. And remember to eat a balanced diet, quit smoking, limit alcohol intake, avoid sugars and processed foods and artificial ingredients. If you don't feel well, also make sure to get your rest. Otherwise, get some regular physical activity, get some fresh air, manage those stress levels, and get a good night's sleep. This concludes today's People's Health Briefing. We will see you next week, Tuesday at 10 a.m.